achievements and awards, we can see she has received President Appreciation Award and Proficiency Award at ISACon Agra and President Appreciation Award at ISACon Solapur 2019, Pain Ambassador Award at ICRA Pain in 2019. So I welcome Dr. Sunita as session moderator of this talk, where Dr. Sujit Gautam is going to present. So over to you, madam.
Thank you so much. Thank you, Dr. Chinmay. Good evening, everyone. I know today's topic, it is very interesting, and I think so we all will be definitely putting some inputs of theirs also, their experience, like what are they doing, because as we all know, post-herpetic neuralgia, it is a very challenging condition, and it is a recurring pain which keeps on nagging the patient in spite of all conservative therapies, and many a times till the time they come to us, I mean the pain physicians, they have taken multiple drugs also. They are on conservative therapies along with alternative mode of treatments like TENS, and peripheral like acupuncture also has been tried in many of them, and then various medications, lotions, cold therapies, and what not. I think so, like aspirin, capsaicin, lignocaine, these are routinely given to them. But then when they come to a pain physician, it is we have to start from start, like how it started, how many months, because everything depends on pathophysiology and the duration of the sufferings and the development of herpes zoster. So accordingly, like it is being divided into various phases, and even the line of treatment, like first line, second line of treatment is decided depending on the duration of the symptoms also. So in detail, one has to know about the pathophysiology of the condition, the treatment modalities, the various interventions, which one to start with and how to proceed accordingly. And the most important is the preventive measures. So if the prevention is taken in acute phases, that is, the awareness is very, very important for these conditions. And as we all know, like even the vaccine has been developed, and it is said that if the vaccine is given to all those who are over 50, definitely it is going to prevent the incidence of post-herpetic neuralgia. So to give us, enlighten us on this topic, we have a well-known pain physician, Dr. Sujit Gautam, with us. He is additional professor, Department of Anesthesiology, and is at present working in Lucknow at SGP GIMS. And his main areas of interest are chronic pain management. He has received postdoctoral certificate course in pain and palliative care from the well-known Institute of RNSE, that is BHU, and has various international and national publications to his credit. So he is managing chronic as well as cancer pain. So his main area of interest is chronic pain, and of course palliative care clinic is also out there. So I think so Dr. Sujit Gautam, he's going to tell us in detail about the all phases, that is acute, subacute and chronic, and over to him for the talk. Dr. Sujit Gautam.
Thank you, Dr. Sunita, for the kind words of introduction. So I'm now sharing my screen.
Yeah. Any questions during the talk, you all can put, you can start sharing. You can put in chat box, which will be answered afterwards. And I think so it should be a very lively interaction amongst all those who have joined today's webinar. You can start, Doctor.
Okay, Dr. Sunita, thank you very much.
Welcome.
So good evening, everyone. It has always been a very special feeling to make presentation, to interact in the sessions organized by the Daradia and Dr. Gautam Das. So yeah, I would like to congratulate Dr. Gautam Das and Daradia Pain Hospital for successfully organizing the annual conference of the West Bengal Society for the Study of Pain. I'm sad that I couldn't participate in the event on account of some personal reasons, prior commitments. It's a great event. I have received, I've been following through the WhatsApp group itself, but congratulations, sir. Yesterday, I received COVID vaccine. So there were some mild symptoms in the form of dizziness and some myalgia. But overall, it has been a nice experience. So to begin with, regarding post-herpetic neuralgia, these are the common terms which are commonly associated with, commonly talked about in relation to post-herpetic neuralgia. So I thought it would be useful if I begin my talk describing these terms. So chickenpox or varicella, it's a primary infection with the varicella zoster virus. And herpes zoster is basically reactivation of the dormant varicella virus, which have gained entry during the chicken pox and are lying in the dorsal root ganglia. And they are reactivated on account of decreased immunity. And post-herpetic neuralgia, it's basically a complication of herpes zoster, and it refers to pain persisting 3 months after the onset of herpes zoster rash. So the rash of chicken pox basically consists of vesicular lesions on an erythematous base. And these are basically concentrated on the face and trunk. While the rash of herpes zoster is quite localized one, and the lesions are primarily unilateral, painful in the form of vesicular rash, and it follows a dermatomal distribution depending upon the sensory ganglia which are involved. And post-herpetic neuralgia, it's basically a complication of herpes zoster, and it usually presents in the form of hyperpigmented scar in the area of the rash, and patients usually complain of pain, allodynia, and hyperalgesia. So before discussing post-herpetic neuralgia itself, I shall be discussing few slides on herpes zoster. Regarding risk factors, age and immunosuppression are the two most common described risk factors. Old age is the most important risk factor, and 20% cases are seen in the age group of 50 to 60 years, and after 60 years, 40% cases. Immunosuppression or decreased immunity is the reason if we consider the old age or many conditions like organ transplant or steroid supplementation. And besides these two risk factors, these are the other factors which are described that it is more commonly seen in the females. Then the incidence is somewhat lower in the Black population. And few comorbid conditions like HIV, malignancy, and chemotherapy, which are primarily associated, giving rise to decreased immunity, are also risk factors. So the transmission, the mode of transmission is primarily via droplets, aerosol, or direct contact with the lesions. And lesions are considered non-infectious after the crusting phase. Coming on to the clinical features regarding the rash. Rash is basically unilateral and erythematous papules in a single dermatome. And it passes through stages of vesicles or pustules 3 to 4 days after the appearance of the rash. And the lesions crust in a period of 7 to 10 days. And overall, the rash is over usually in a period of 2 to 4 weeks, followed by scarring with hypo or hyperpigmentation in months to years after herpes zoster. Pain is a very common symptom of herpes zoster, and the reason is acute neuritis because of the reactivation of the virus, and which gives rise to the inflammatory response because of replication and the viral transmission. So it's a peripheral neuropathic kind of a condition, and it gives rise to burning or stabbing sensation, very severe pain. And prior to the appearance of rash, in most of the cases, pain appears prior to the appearance of rash. So it is described as prodromal pain, and it is also one of the risk factor for the post-herpetic neuralgia. Now, these are the few important complications of herpes zoster. Post-herpetic neuralgia is one, and it is said to be the most common complication of herpes zoster. Then there is herpes zoster ophthalmicus, where there is involvement of ophthalmic division of the trigeminal nerve. Then herpes zoster oticus because of involvement of 8th cranial nerve. Now, the diagnosis is primarily clinical. There is a painful vesicular rash in our dermatomal distribution. And most of the times, the diagnosis of herpes zoster could be made with this clue. But if there is some confusion, then PCR test, that is polymerase chain reaction test, can be used. It's a highly sensitive test. And the specimens can be taken from the lesions of the rash or CSF or blood. Now, coming on to the treatment. Antiviral therapy is the basic treatment of herpes zoster, and it is said to reduce the severity, pain, and duration of the acute stage. Regarding its preventive role in post-herpetic neuralgia, evidence is rather inconsistent. Few studies say that it prevents, few studies say it doesn't prevent. And the Cochrane review in 2014 says that acyclovir has got a very minimal role, hasn't got any role in the prevention of post-herpetic neuralgia. And other antiviral medications like famciclovir and valacyclovir, more studies are required. So regarding the timing of therapy, these antiviral therapy should be started within 72 hours after the onset of rash. These are the antiviral medications which are primarily described in literature, and the therapy period is of 7 days, and the dose and dosing pattern and the dose is different. Acyclovir, owing to its low bioavailability, has to be prescribed. The dosing time is less. And famciclovir and valacyclovir, owing to their better bioavailability profile, requires less frequent dosing. Valacyclovir, on account of a few studies have pointed out that valacyclovir has better outcome than acyclovir. And across the literature, all of them mentioned that topical antiviral therapy is ineffective. So it is of no use to use antiviral creams in the management of herpes zoster. Then pain is a very common symptom of herpes zoster. If the pain is mild, then it can be controlled via acetaminophen, paracetamol, or NSAIDs. However, moderate to severe pain requires treatment quite similar to that of post-herpetic neuralgia. There are anti-neuropathic pain medications, and weaker opioids are useful option. And one interesting option, which I haven't used, but it has been described in literature, is oral prednisolone, especially in the older population, which are more prone to develop post-herpetic neuralgia itself, and 60 mg per day, and tapered over a period of 10 to 14 days. Then role of interventions, most of us look for interventions as an option, therapeutic option in this condition. And NEUPSEG recommendations published in 2013 provide a weak recommendation for epidural or paravertebral local anesthetic and steroid nerve blocks for the relief of acute pain of herpes zoster. And they also say that nerve blocks should be reserved for patients who fail pharmacotherapy. And another thing they have advised that repeated epidural and paravertebral injections of local anesthetics and steroids early in herpes zoster may prevent post-herpetic neuralgia. So there is a possibility that these interventions, if repeated at regular intervals, may prevent the appearance of post-herpetic neuralgia. So now coming on to post-herpetic neuralgia, these are the risk factors, and old age and immunosuppression are like the herpes zoster are the risk factors. And apart from those, severity of the herpes zoster, severity of the rash, severity of the pain, and presence of prodromal pain are itself the risk factors for developing of this complication of herpes zoster. Then clinical features. The pain is a very important symptom of this complication, and usually patients present with three categories or kinds of pain patterns. One is the spontaneous burning and shooting pain in the area of rash. Allodynia is present in majority of the population presenting with this thing, and hyperalgesia. Along with this, there might be some sensory disturbances in the form of numbness, itching, and paresthesia. And on account of this severe burning pain, sleep might be impaired. And along with that, and there might be few psychological disturbances. Now, very briefly, the pathophysiology of post-herpetic neuralgia. Well, herpes zoster, on account of reactivation of dormant varicella virus as a result of decreased cell-mediated immunity, may give rise to peripheral sensitization. Well, in this inflammatory response triggered by the viral replication and axonal transport causes cell death in the peripheral nervous system. And as a result of this, the threshold for nociceptive stimuli at the periphery decreases. So the threshold phenomenon for the threshold stimuli required for this stimulation of peripheral nociceptive decreases and pain increases. Then this phenomenon also gives rise to central sensitization, where the inflammatory changes at the level of dorsal horn contributes to increased nociceptive transmission, increased transmission of painful stimuli, and also there is impaired functioning of inhibitory descending pain pathway. So overall, there is increased generation of painful stimuli, nociceptive stimuli at the periphery, and increased pain transmission of these impulses at the center. So that is why it is said that interventions which decrease pain, inflammation, or tissue damage during the acute phase may lessen the likelihood of post-herpetic neuralgia. Now, coming on to the treatment of post-herpetic neuralgia, I have kept this statement as a first part because to tell that how much difficult it is to treat this condition or provide a pain relief in these kind of patients. A reduction of pain by 30% is considered clinically significant. And reaching this goal in PHN patients is usually accomplished only half of the time. So if we are lucky and patient is complaining of mild to moderate pain, topical capsaicin cream is suggested to start with a concentration of 0.075% and applied 4 times a day. However, in many of the patients, or rather majority, the pain is of moderate to severe category. And these are the options which are suggested. If the pain is localized, one can use 5% lidocaine patch, or alone or in combination with gabapentin or pregabalin. And across the literature, it is suggested that better to avoid TCAs, tricyclic antidepressants, because majority of these patients are of older age and they must be having some other drugs. So TCAs, owing to their poor side effect profile, should be avoided if we can provide pain relief with gabapentinoids. Now, regarding opioids, it has been suggested that one should use this drug very carefully in post-herpetic neuralgia. And if the pain is of severe category, one should establish its goal very clearly, that as soon as the pain scores are going to decrease, the opioid dose or opioid itself will be tapered off, because long-term efficacy and safety has not been established, and there have been so much issues associated with its use. Acetaminophen and NSAIDs as per the requirement. Then few points regarding capsaicin 8%. The application time is 60 minutes, and topical lidocaine is required because it causes severe burning pain at the site of application. So at the site of application, topical lidocaine is injected prior to the application, and it is advised to it is basically applied in a health setting with monitoring for up to 2 hours after the treatment. Now, regarding role of interventions for post-herpetic neuralgia, the NUPSIC recommendations say that sympathetic blocks should be avoided. And this recommendation has been formulated on the basis of low quality evidence indicating no benefit. Sympathetic blocks are beneficial in the acute phase of herpes zoster, but not in the chronic phase. Well, this was something interesting. That is, the intrathecal methylprednisolone and lidocaine was reported to be effective in one of the studies published in NEJM in 2001. And based on this publication, the American Academy of Neurology, in their recommendations published in 2004, gave a good recommendation for this intervention. However, concern was raised about the safety of this intervention in the form of risk of arachnoiditis and fungal meningitis. And presently, it is not advised for routine clinical care. Then there is limited evidence for intrathecal pumps, spinal cord stimulation, and deep brain stimulation. Now, these are the recommendations from the World Institute of Pain, published in Pain Practice with an updated version in the year 2018. And the interesting thing is that they have given moderate recommendations, moderate evidence, or weak recommendations for the role of epidural or paravertebral injection of corticosteroids with local anesthetics in the acute phase, that is the acute herpes zoster. There was an interesting recommendation that moderate evidence for pulse radiofrequency lesioning of intercostal nerve, or DRG, for post-herpetic neuralgia. Apart from this, they have also strongly against the use of intrathecal administration of corticosteroid, and were against the role of sympathetic nerve blocks in case of post-herpetic neuralgia. So overall, the two recommendations, one from IASP and other from World Institute of Pain, are similar. And I was happy because most of the times when we go across recommendations from different societies, there is less likelihood that the two recommendations are talking in one line. Then I thought it would be useful to discuss those two studies which have utilized PRF lesioning for PRF lesioning of intercostal nerve, or DRG, for post-herpetic neuralgia. So this first study, it is from China, Shanghai, and it was a double-blind RCT with an impressive sample size of 96. And they did a PRF lesioning of intercostal nerve at the level of zoster lesion and segments above and below. They did 2 lesions. And what they concluded that pain scores and analgesic consumption was decreased, along with significant improvement in the quality of life for a period of 6 months of follow-up in the PRF group as compared to the sham group. So it was a double-blind randomized controlled trial. Then the one which on the DRG for the PRF lesioning of the DRG, it was a open label retrospective study. The sample size was 49, and they retrospectively reviewed cases where they did PRF lesioning of cervical, thoracic, or lumbar DRG in patients with PHN. They did 3 lesions at each level, and their follow-up period was somewhat short. 12 weeks follow-up period was there. And they concluded improvement in pain scores during this follow-up period after PRF lesion. Now, this 2 more interesting studies I would like to discuss before concluding. And this was quite an old study published in year 1993 in Regional Anesthesia and Pain Medicine. And it's a retrospective study. It was interesting. And they have studied the relationship between timing of treatment of acute herpes zoster with sympathetic block and their role in prevention of post-herpetic neuralgia. So they carried out this study to study the relationship between timing of treatment and their preventive role. So they retrospectively reviewed 122 patients treated at variable intervals after the onset of acute herpes. And what they found that sympathetic blocks terminated the pain of acute herpes zoster and prevented or relieved PHN in more than 80% patients treated within 2 months of the onset of acute herpes zoster. So they concluded that if sympathetic blocks are administered within the 2 months of acute herpes zoster, it is offering good relief and it has got a preventive role. And the reason they put forward was the fact that probably by restoring intraneural blood flow, and thus preventing the death of the large fibers and avoiding development of PHN. And if these blocks are administered afterwards, that is after 2 months, it is less likely that they may prevent such kind of a thing. Now, finally, this study from Japan published in 2020 itself, and they studied the role of continuous epidural infusion, and they have two groups. One was a contrast group in which they did the epidural infusion conventionally by injecting contrast. That is, they confirmed the epidural space by injecting contrast under fluoroscopy guidance. And in the other group, they used epidural catheter with a guide wire, and they detected the site of epidural drug injection by passing current, and where they achieved the sensation at the site of zoster, at the site of complaint by the patient. They leave their catheter at that place. And in the both groups, they did a bolus injection followed by a continuous infusion for 10 days. And what they concluded that pain score was significantly lower in the stimulation group than in the contrast group for 6 months after the procedure. So it was an interesting thing that if we are localizing our site of injection in a better manner, maybe it is going to improve our results and has got a better preventive role for post-herpetic neuralgia. So to conclude, I would like to say that pain control is important in the early stages of acute herpes zoster. Pharmacotherapy and interventions are useful options in acute herpes zoster. And there are weak recommendations for epidural or paravertebral local anesthetic and steroid nerve blocks. Regarding post-herpetic neuralgia, 30% pain relief is said to be clinically significant. Very important that one should explain the prognosis to the patient before starting the treatment. There is good evidence for pharmacotherapy. Regarding interventions, evidence is limited, should be used very carefully, and there might be situations when pain is severe and drug side effects. Pharmacotherapy, one has reached the upper limits of pharmacotherapy. So in those cases, for short-term benefits, one may use these interventions. But one should clear with the aim that intervention is not going to achieve much long-term benefit, and one should use intervention only those with which one is well versed with, and the logistics are available for it. Thank you very much for my talk.
Thank you, Dr. Sujit. It was indeed a very precise demonstration which included the pharmacology and the various modalities like conservative management and interventions. Various school of thoughts keep on coming when a patient of post-herpetic neuralgia enters a pain clinic. So in short, the conclusion from your talk says that the ideal treatment of post-herpetic neuralgia, it involves rational polypharmacy, and one has to understand the pathophysiology first and the pain mechanism, basically what has caused this post-herpetic neuralgia. Since there is no evidence and good data regarding these additive or synergistic benefits of these combination treatments, so it is really very difficult to come to a conclusion that which patients are going to be likely benefited with which modality and which medications. Since various non-pharmacological therapies are also there which have been tried, until the patients reach the pain clinic to the pain physician, they have tried and everything has been exhausted. So that is why the role of interventions comes, because basically the pain factor has to be taken care of. And hence the modalities, though it is said that there is limited evidence, but then also definitely they at least break the pain cycle and patients get some relief. So it was a very good presentation. Congratulations. There are various questions for you. I think so I'll start. The first question is from Vasudha Jadhav, who is asking for the trade name for capsaicin cream. It is available and you can, do you know the name capsaicin cream?
Right now, I'm not aware of. I will inform it. I will.
Yeah, but like in Nagpur, it is Ranbaxy has one which is Capsidol Vasudha, and the second from Sun Pharma, that is Capsaicin P, are available in the pharma center. So even if you write capsaicin cream, they give it. If it is usually it is available in the medical shops. So these two companies, Sun and Pharma, are there. The second question is from Dr. Umesh Ramtani. Is there any role of intra-regional or peri-lesional local anesthetic plus steroid injections? Any role of intra or peri-lesional local anesthetic plus steroid injections?
Well, if you look at the recommendations, they haven't mentioned it. The only intervention which has been given a good recommendation is epidural or paravertebral local anesthetic and steroid injection. It may offer short-term benefits, but long-term benefits are not there.
Exactly. So there is no need to give this intra or peri-lesional local analgesics, local anesthetics. But if the patient is in severe pain, one can think of giving them along the dermatome, which gives very good results, along with the patches like lignocaine patches there. I don't think so. 5% lignocaine, it is not available in Maharashtra. Whether it is available at Varanasi or not, I don't know, because it really had very good effect.
Availability is an issue.
The availability is an issue, and I keep asking the company people, so they say it's not available. So if
can I interrupt?
Yes, sir. Yes, sir.
Okay, very nice discussions going on. So I was just listening this question, that whether the intralesional or perilesional local anesthetic can be given, local anesthetic plus steroid. Definitely there is no evidence of Sujit has clarified it, but I have seen seniors to give it. Particularly I have seen the physicians, surgeons, the people, they are giving the local anesthetic and steroid mixture, just below the lesion, means starting from around the lesion and keeping the needle. But exactly how is the result, no evidence are there. So I myself do not practice it, but what I have seen seniors to give it. That means this is one of the, maybe, earlier treatment was there, but unfortunately many things goes on. Unless there is some evidences, we should not be including those things in our practice.
We can give along the dermatome. The dermatome definitely helps, but not in the lesion, I think so. So have you seen anyone giving Botox?
No, what I have seen it, they have given, they have pierced the needle around the lesion and then the needle below the lesion in the subcutaneous areas. I have seen this kind of things.
Okay. Sir, have you seen anyone, sir, any experience of Botox? Because I have not given, that's why I'm asking.
No, I don't have any experience
because
of Botox.
Because it was mentioned one of the modality. That is right. Even I have not given.
Botox injection is one of the very important treatment options for the resistant neuropathic pain, any kind of pain. But in basically in the post-herpetic neuralgia, for the interventions, almost every interventions have very limited role or no role at all.
Exactly. Thank you, sir. Dr. Sujit, one more. The next question for you. Kindly enumerate sites of application of lidocaine patch and precautions as it is water resistant. Have you used lidocaine patches?
My experience is limited for the lidocaine patch.
Okay.
My experience is
when it was available, I used to use this. That was 3 to 4 years back. It is not now available, but yes, definitely.
Sunita, again, it is again available. Modi Mundi Pharma has bought it again. Earlier, it was by Zydus.
Yeah, Zydus.
3, 4 years, 5 years back, it was Zydus. Then Zydus done it because telling that, okay, no sell, nothing. Then last year or maybe, 1.5 years, the Modi Mundi Pharma has again reintroduced it in the name of the Lidovelor patch. So Lidovelor patch is available.
Okay, it's
right.
I'll search, sir.
The only thing which is advised is that one should not use more than 3 patches a day.
Yeah, not more than 3, and you have to apply it for 12 hours and then you have to remove it. No need to keep on don't continue it for 24 hours. So after 12 hours, you have to remove it because of its bioavailability. And then you can again start, and maximum of 3 patches can be used to cover the area. So along the dermatome where there is severe allodynia and pain, you can definitely use these patches along that path, and it gives very good relief. Sir has said, so I'm going to search for it, because we definitely get a lot of patients, and really feel handicapped when there is no patch available.
Only limiting factor is cost. It is very costly. One patch costs 600 rupees something.
600 rupees.
So that is one of the important limiting factor.
Exactly, sir. And only the side effect of this patch, what someone was asking, is that there is some local irritation and redness, but nothing to worry about. So after 12 hours, say, you have to remove the patches. Again, after 12, say after 24 hours, you have to apply the fresh along that. So 3 patches can be applied at one time. The next question is how to give lignocaine before capsaicin. There is a question from how to give lignocaine before capsaicin. It is a topical application which provides a barrier, nothing else.
0.075%.
Yes.
It's only meant for 8% cream, 8% patches Cutenza, and I don't feel like it is available in India. And more so, it is a topical infiltration kind of a thing.
Means you put the infiltration, or you put that cream, lidocaine cream, 2% cream is there.
Application, infiltration.
Yeah. Both have been mentioned. Even we can go for local application also with the cream.
No, I have used Cutenza. That is just topical. Topical, you have to use the lignocaine cream, and then you can use Cutenza 8% also.
Yes.
Chinmay, is it available in India?
No, I used it outside.
So 8% is not available in India.
8% is not available.
Yeah.
Right. And lignocaine is advisable only for the 8%.
Yes.
So whatever is available in India, 0.07%, for that lignocaine is not needed.
Not advisable.
Yeah. This, and Dr. Sujit, you have explained it in your slide also, that application is only for 8%.
8%, yes.
Yeah. One question, is there any role of EMLA?
I'm not aware of.
It is nothing but you
EMLA means it is like Prilox in India. Yes. It is like Prilox available. It is similar to that.
It is a euthetic mixture of local anesthetics, prilocaine and lignocaine, nothing else. So definitely it is going to give local soothing effect.
Right. Actually, what I'll be telling you that when the lignocaine patch was not available, in India, very recently available. So earlier also, I have seen many pain physicians are using this Prilox cream. I also have used Prilox cream when the lignocaine patch was not available, and applying it and putting a dressing over there. So it might be having some temporary effect, but again, if you are asking, because you need to have a continuous release form, then only it will be available. Otherwise, it will be having a very short-term effect. So it is definitely not recommended. But when you have nothing, so you can try for a small period of time.
Exactly.
Basically, one fact which I would like to share is that since in both acute herpes zoster and post-herpetic neuralgia, the severity of pain because of neuropathic component, and in most of the cases, people instead of increasing the dose of one single anti-neuropathic, they use a combination of a neuropathic medication, anti-neuropathic pain medication. So, and usually what happens, the anti-neuropathic pain medication also takes time to produce its effect. And during this interval, patient is having severe pain. So it is very important to use weaker opioids in combination of paracetamol or NSAIDs to optimize pain relief to the patient, so that patient is having pain relief. And by the time the effect of anti-neuropathic pain medication comes, one can taper off the dose of opioids. So in this part of 1 to 2 weeks in which patient is having severe pain and anti-neuropathic pain medications haven't produced its effect, that's a tricky thing. And many times higher dose of opioids is required in this duration, because since we don't have a lidocaine patch with us, or if available, cost is an option, cost is an issue. So this is one thing which I personally do at my place, that during the period of 1 to 2 weeks, somewhat higher doses of tramadol like Ultraset 4 to 5 times a day, along with anti-neuropathic pain medication. And once the effect of this pregabalin or gabapentin comes on, then one can taper it down.
Exactly. Dr. Sujit, any experience of IV lidocaine or IV ketamine, because there is some central sensitization also. So have you tried that in resistant cases?
In few cases we have used, but the effects are short lasting, not very long lasting. Acute herpes zoster, my personal experience is not much, but regarding post-herpetic neuralgia, 2 or 3 cases we couldn't offer much relief to the cases. And few cases, like majority of the cases are coming to us in a duration of like 4 to 6 weeks. So in those cases, the output is somewhat better, but in long-standing cases like 8 months, 9 months, the effects are not very long-lasting for lidocaine, ketamine, or lidocaine steroid kind of a combination.
Yeah, but basically, at least we can break the pain cycle, which is there. Because in resistant cases, when we have tried everything, one should try this before shifting to the stimulators and peripheral, like intrathecal drug delivery systems.
Well, as Dr. Gautam has also said, that interventions have got a very minimal role.
Yeah, exactly.
And all the interventions offer short-term pain relief. The only thing is that one has with is the use of this anti-neuropathic pain medications with them. So for short-term results, interventions may be of help, but for longer term, we don't have much of help with the interventions.
What is your protocol? How you give ketamine? Like, what is the dose exactly? So the others will know. That's why I'm asking.
Ketamine, like as I've also discussed with Dr. Das previously. So most of the cases, lidocaine we have used more rather ketamine, and lidocaine like 3 to 5 mg per kg. And over a period of 30 to 45 minutes infusion we used to give. So that is one thing we used to give. And for ketamine, we used to 0.5 to 1 milligrams per kg, and over a period of 1 to 1.5 hours.
Okay.
Sometimes we mix it together. Sometimes we mix this 3 to 5 per kg lidocaine and 0.5 to 1 milligram per kg body weight of. Normally we start with the lower dose, 3 milligram or maybe 0.5 milligram ketamine, and use in a same bottle or same syringe pump and transfuse over a period of around 1 hour. And then gradually next day, if the patient is tolerating nicely, everything should be done under the monitoring. If the patient is tolerating nicely, then next day we can increase the dose. Next subsequent days we can go to the higher doses. But again, what you told is very important, that immediate relief might be there, but the long-term effect is not there. That is one of the very important limiting factors.
You like to use that lidocaine ketamine for PHN part, for PHN thing?
No, I have not used, or maybe only one case or something like that. But I have not used. I have used it much for the fibromyalgia cases.
Yeah.
Fibromyalgia patients, all over the body is pain is there. So in those patients, my experience of using the intravenous lidocaine and ketamine in those cases.
Yes. And always, I use for fibromyalgia, and I pre-medicate these patients with ondansetron and midazolam to prevent the hallucinations. Okay. So that also works very well. Even I have not tried for herpetic neuralgia, post-herpetic neuralgia.
And I'll be sharing another thing, not much cases, only one case I tried the trial stimulations long back, post-herpetic neuralgia, and spinal cord stimulator trial stimulation didn't help. So it is not that, if spinal cord stimulator also going to help, it is not like that. About the recommendations and the evidence, the evidence for the spinal cord stimulator is also not very high in post-herpetic neuralgia.
There is one question for
you, in my opinion, in my experience, what I have seen out of all the different kinds of interventions, I have seen the pulse radio frequency have some value. Yes. At least in some cases, pulse radio frequency of the dorsal ganglion is having some better results than compared to the other interventions. But again, failure is also there in pulse radio frequency.
In some patients, we get very good relief. In some, we don't get anything. So always it is a dicey situation. There is one more question for you.
Good evening, sir.
1 minute, Pratibha.
Yeah.
Hello.
Hi, Sunita.
Hi. You want to ask something?
I didn't want to ask. I just wanted to share my experience.
Okay.
In our institute, we get a fair number of cases of herpes zoster. Most of them, since it is an institute, and we have a quite good awareness about the post-herpetic neuralgia and the pain associated with acute herpes zoster. So we have a very good dermatology department who usually refer them in the acute phases. So we have the protocol. Most cases we get is herpes of ophthalmicus and the thoracic herpes zoster. So we usually combine it with the multidisciplinary approach. Like we start them on neuropathic medication. We give them even in the acute phases when the vesicles are like little dried. Then we give them supraorbital supratrochlear block if it is in herpes ophthalmicus, and paravertebral block for the thoracic dermatomes.
Yeah.
And many a times we also put catheters, and in my experience it really works well. If the patient has resistant pain or PHN, then I always like to combine along with the intervention lignocaine and ketamine infusion. I usually use in the dose of 3 to 5 milligram per kg for lignocaine and 0.3 milligram per kg, because most of our patients come from villages and they have to travel back home. So I like to give it in a little lower dose of ketamine rather than giving 0.5 and 1 milligram per kg. And I have found very minimal side effects with this dose of ketamine, which I give it over a period of 1 hour, and it is continued for 5 to 7 days, which is given on an OPD basis. So that's my experience about the treatment of acute phases of herpes zoster. I feel the paravertebral blocks for thoracic herpes zoster really works very well if it is an acute phase, because we follow up the patients for longer duration also, and we have found that the incidence of PHN is quite less if you have treated them in the acute phase.
I think so.
But if they come with the later phases, and especially if they are associated comorbidities are there, then the treatment is very resistant. They are very resistant to treatment. Even the interventions, the paravertebral blocks don't work much if they are associated comorbidities.
Exactly. This paravertebral blocks, I think so that awareness has to be there, and we should tell the dermatologists that if these patients are referred to us at this stage, especially the acute one, I think so we can do something so that this can be prevented, post-herpetic neuralgia.
Yeah, in our institute that there is a very good awareness, and we get fair number of cases. We get lot of cases of herpes zoster in the acute phase itself.
Great.
We do a lot of interventions.
What is the dose and what are the drugs which you give for paravertebral block, Pratibha?
We usually give 0.25% bupivacaine and along with either dexamethasone mostly in 15 to 20 ml.
Okay.
If it is a single shot,
because I read in one article that they gave clonidine with sensacaine, and they had
you can relief. Combine, because anyway it is an alpha 2 agonist, and it also works well on the neuropathic pain. So you can combine. That's like, but the routine protocol for us is sensacaine and dexamethasone.
Okay. There is one question. Thank you, Pratibha. One question for Dr. Sujit. How long gabapentin to be continued?
How usually we do use in a period of like 3 to 6 months in our cases, but I have seen many cases in which which don't allow tapering, longer periods like 9 to 12 months they have continuing this medication. There is no clear-cut answer for this question in the literature also mentioned, and one has to be very careful when the patients we have to use these medications in a longer period, but in majority of the cases 3 to 6 months.
Yeah. Even I have read in some articles that they have continued it for one year also.
Yeah.
So it depends on the symptoms and severity, I think so. Dr. Chinmoy, your experience for this gabapentin?
Yeah, I mean, like, nothing, I mean, out of the way. I mean, like, it is similar to all other neuropathic pain, same way.
Exactly.
Yeah. But I will share one thing that Dr. Pratibha said about this paravertebral block and all. No, for intervention part, my experience is different. I gave to this, I mean, like thoracic nerve root. There, I gave local anesthetic 2% lignocaine in 3 consecutive patients, and I failed. Then I understood what is central pain. Then I just stopped doing all intervention in post-over herpetic neuralgia. Then my good experience with this lignocaine patch, and luckily I got to use 8% capsaicin also. 8% capsaicin also gives a good result.
Yeah, the local patches and the conservative management with gabapentin and tricyclic antidepressants. Yes. This is the first line of treatment. One more question: is neural intervention contraindicated in acute phase? Pratibha has given right answer for this just now. Dr.
Neural
Sujit?
Intervention, like, okay, nerve blocks kind of a thing, you mean?
Neural intervention means any type of block, paravertebral, epidural.
No, it is not contraindicated.
Are they contraindicated in acute phase?
Yeah.
But I think so we should wait for the effect to come of the drugs which are started in acute phase. Or we should...
That is what recommendations have said, that one should wait only in those cases that pharmacotherapy hasn't proven hasn't given adequate effects. In those cases, one should go for neural interventions.
Exactly.
And Dr. Pratibha has already told wonderfully that how one should use paravertebral blocks in these cases of in the acute phase especially.
Yeah, provided we get the patients in acute, we can form that protocol, and a study can be done. In their institute, they have done the study also, and they found very good result because these patients were caught at early phase, that is acute. So
they are adhering to the protocol. Their protocol is strictly as per the recommendation.
Yes, as well.
Wonderful to hear about.
Yeah, and that is why I think so. The study in which you mentioned that sympathetic block administration within 2 months of acute herpes zoster. Has preventive measures.
Yeah.
So that was the first study at level. Means the slide, the second slide before you completed your talk, it was there. So I think so. Sympathetic blocks and paravertebral blocks definitely have a very good role.
Definitely.
So I think so. There is one question: can you summarize the treatment protocol, because it is not very straightforward anywhere. It is not given anywhere. So this is one more question.
No,
it is for everyone. Dr. Chinmoy, you can tell Dr. Sujit, anyone, if Sir is there. I think so. Sir has gone for a meeting.
Okay, fine. For the herpes zoster, it's a combination of antivirals and analgesic and antineuropathic pain medications. And if one is not achieving benefits with these 3 modalities, then one can go for paravertebral and thoracic epidural. And if the site is outside this territory, then one can go for neural blocks. Regarding this post-herpetic neuralgia, analgesics along with the antineuropathic pain medications, and in the initial phase when the antineuropathic pain medication hasn't produces its effect, then one can go for one should use opioids, weaker opioids like tramadol in a good amount of dose, so that patient has a good amount of pain relief. And as soon as one achieves good pain relief, the antineuropathic pain medication has produced its effect, like after a period of 2 weeks, one should taper down the dose of opioid. And if the pain relief is not there with these 2 options, then intermittently one can go for sympathetic blocks or neural blocks like thoracic paravertebral or epidural to offer some relief, and see subsequently if some benefit can be achieved with antineuropathic pain medications. So this is what I usually follow. I don't I haven't used steroids in cases of acute herpes zoster because my experience is somewhat limited for acute herpes zoster. Maybe if someone from the audience can share their experience, or you would like to have a few words regarding the use of steroids in acute phase.
Actually, whatever prescriptions I get from the dermatologists when they refer the patients for this pain, they already give steroid in the acute phase, oral steroids.
Okay.
So maximum prescriptions from them, skin specialists, they the steroid is there, because I think so that pain and inflammation part has to be taken care of.
Okay, that's
Your
fine.
experience, Dr. Chinmay?
I do not get usually acute herpes.
Yeah, maximum what we get is this. But when I see the prescription, so that time I saw that in the acute phase, when they went there and the treatment was given, steroid was added in tapering doses. So the first 15 to 21 days steroid is usually given to them. Many a times, few patients who came to me with pain and burning, and then when I saw lesions, when they came in early phase, so the antivirals and everything, when it was started, it really gave very good relief, because lignocaine patches are not there out here. But as Sir has said, even I'll search from Modi Mundi. If we get it, we are very lucky.
Yeah, Sunita, this Modi Mundi has this buvular, this lidocaine patch, and
lidocaine 5%.
Lidocaine, yeah, lidocaine patch only, and actually it is not costly because it is 600, and there are 2 patches inside. So actually it becomes 300 rupees per patch.
So it is 6 this thing now 5% one now you are telling.
Yeah, 5% only.
Sure,
it is
sure,
now
yeah, because I keep asking Pratibha, that is why.
Yeah, I'll just maybe forward you the number of the person and the patch, also the details of the patch.
I would, okay.
Yeah. So it is not costly also. What I wanted to say is it is 600, but there are 2 patches in the pack. So it is actually comes to 300 rupees per patch.
So you can cover that whole area where the pain and allodyniasis. Recently, I think so 15 days back, when I got one patient who was referred, after giving the block, the pain continued along the dermatome. And since it was mentioned, and I do a lot of IMS, so I did along that dermatome. And the patient came, I did 3 to 4 sittings. This was not US guided. It was as I used to practice before ultrasound was available. And when the patient came, say after 1 week, 3 sittings were done, he said that he felt much better. This I had read somewhere, so I said, why not to try in this patient? This is just one addition to our talk, since it is related to post-herpetic neuralgia. And this patient was suffering from PHN since last 1 year. So this is, I think so we should conduct studies, and then only we'll come to know whether acute dry needling helps or not.
So what is the duration of patch, like for one lignocaine patch? For how many days do you continue to use it?
See, one lignocaine patch, it maximum, see, you have to first see the area where the allodynia and pain part is there. And then according to that, the size of the patch, there are 2 patches, as Pratibha said, in one packet. So you can apply it over there. There is no need, the area should be dry. Okay, non-hairy. You have to remove it after 12 hours.
12 hours, okay.
The duration of action is for 24 hours. So after 12 hours, 12 plus 12, 24, again you can apply the next one. Because it will cause a lot of erythema and redness. So we have to give that much time for the skin also.
So that means after 12 hours of removal, again you can reapply it. So
yes, you can reapply after 24 hours. Suppose you are applying today at 8 o'clock and evening 8 you have to remove that, and next day at 8 o'clock again you can apply. Maximum of 3 patches. So that covers the dose. It's like that.
Thank you.
I think so there are no questions, and there was very good and lively interaction. Thank you. I think so we conclude the session, sir.
Yeah. Actually, Dr. Das is not there probably. So on behalf of Dorodia, I thank you all. I thank Dr. Sunita for conducting such a nice session, and Dr. Sujit for enlightening us. We recollected many things. So I think we can call it a day. And thank you all again. Good night then.
Thank you. Thank you so much. Thank you, Dorothea, for keeping everyone updated, and such nice topics are there where everything can be discussed. And I think so we should continue and do studies at 3-4 centers and then come to a conclusion which we can publish in our journals also, that what is best, which will help everyone. Thank you so much. Have a good weekend. Happy Saturday, Sunday. Thank you.
Thank you.
Thank you, Das sir. Thank you, everyone.
Thank you.
Bye.
Bye.